We are live now, sir.
Okay.
Yeah, Dr. Ajinkya, over to you.
Yes, thank you so much. So I'm sharing my screen. So hello and good evening, everyone. I'm Dr. Ajinkya Nanore from Emcure Pharmaceuticals. I welcome everyone to the No Thrombosis workshop in acute ischemic stroke. Today is the 8th edition of this workshop. In previous workshop, we had a very unique and interesting case discussions, and we are looking forward to have a fruitful discussions today as well. The objective of this workshop is to showcase unique cases in management of AIS and gain insights from the moderators and the wisdom shared by our course director. So it is my honor to introduce our course director, Dr. Subhash Kaul sir. So sir is a senior consultant and specialist, Secunderabad, and also a chairman at KIMS Foundation and Research Center. Sir has been a faculty for 27 years at Nizam Institute of Medical Sciences, Hyderabad. He was also former professor, head at Department of Neurology and dean at NIMS. Sir has more than 120 publications in national and international journals. Sir has been awarded by State Teacher Award by Telangana government in 2017. So, and sir has also been past president at AP Neuroscientist Association and Indian Stroke Association, also an Indian Academy of Neurology. Then I welcome Dr. Jayanta Roy, who is director of Stroke Program and senior consultant at Department of Neurology, Institute of Neurosciences, Kolkata. Sir is a certified neurosonologist accredited by American Society of Neuroimaging. He is recipient of 2005 American Society of Neuroimaging William McKinney Award for the best manuscript based on the clinical research and neurosonology. He has been the executive committee member of Society of Neurosonology India, also a member of educational committee of Joint World Stroke Congress. Sir has more than 35 publications in various reputed national and international journals. He is also editor of various neurology books. Welcome, Dr. Jayanta Roy, sir. Then I welcome Dr. S. Meenakshi Sundaram. Sir is a senior consultant neurologist, Apollo Hospitals, Madurai. Sir has more than 20 years of experience in neurology. He has presented various prestigious and national international forums. Also, recipient of Best Research Paper Award at the 10th National Conference of Indian Academy of Neurology, Lucknow in 2002. He has been a principal investigator for many international trials such as refractory partial epilepsy, stroke, etc. He has also been editor of South Asian edition of the book Practical Neurology and also contributed to many books on neurology. Then I welcome Dr. B.L. Narasimha Reddy, our first speakers for tonight. Sir is senior consultant and neurophysician at Nirmal Neuro Hospital in Telangana state. He has presented multiple posters and papers in national and state conferences. He has been awarded for the best paper presentation in Econ 2016. He was a best outgoing student of the year 2018 from SVIMS University. The areas of expertise are stroke, epilepsy, and migraine. Welcome, Dr. Narasimha Reddy. Then I welcome Dr. Venkatesh Bolegave, sir. He is the assistant professor in Department of Medicine in Neurology at Rajiv Gandhi Medical College and Chhatrapati Shivaji Maharaj Hospital, Kalwa, Thane. He has multiple publications in various journals. He has done multiple poster presentations in various conferences and also won multiple prizes at those conferences. With this, hello, am I audible, sir?
Yeah, you are audible.
Yes. My Bluetooth connection got, sorry for interruption. And with this, I would like to hand over this session to our course director, Dr. Subhash Kaul, for his opening comments and context settings. Dr. Kaul, sir, over to you.
Yeah. So thank you very much, Team Emcure, for organizing this forum. And now it is almost 8 months old. And every month we see some new cases. And the unique feature about this particular forum is that it's a two-way street. and in which we see how stroke is actually being practiced at a ground level, what kinds of risks our younger people have to take in the absence of definite um guidelines, and what kind of rewards they get, what dilemmas they face. And the whole process, we learn ourselves so much and we share our thoughts with them. And I'm very, very happy that more and more people are enjoying it. I also got a lot of good feedback. Recently, I attended a conference in Delhi, and some of the people who have been attending this gave me a very good feedback. So thank you once again. And it's my pleasure to welcome today's participants. And I particularly welcome Meenakshi Sundaram because for some time I was missing him. But today I'm very happy. Meenakshi is one of the old god. Meenakshi was junior to me, but now he's himself very senior. So that can tell you that how old I am. So Meenakshi, it's a real pleasure to have you. So may I please request you to please carry on the proceedings, please.
Thank you very much, respected sir, and thank you, Dr. Jayant Rai sir, for joining us. I will have a small quote to give here, and this quote I'll let you know who has given this quote. We learn neurology treatment parts in neurology by looking at randomized control trials, but it is the individual cases which give us the maximum, approach related ideas. This is a quote by none other than Professor Dr. Subhash Kaul sir. So we are going to learn from sir as well as the enthusiastic participants. You are going to present two wonderful cases. Welcome, sir. And without much ado, I think we can take the case forward.
Meenakshi, has Jayanta joined already?
Sir,
I didn't
his
see
name
him.
was there, but I'm
Okay.
not sure he
Okay.
has
Yes,
actually
yes, sir. He
joined.
has
Sir.
joined.
On telephone, on phone, he was supposed to join. Sir.
Okay.
Yes.
Sir, I'm here on phone. Actually,
Oh,
I'm stuck at work, so
oh,
sorry about
Jayanta.
the.
Welcome, 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 Jayanta.
Namaste, sir.
I'm there, sir.
Okay. Please begin, sir.
Dr. Reddy?
Yeah, good evening.
Yes.
Shall I share my screen?
You can share your screen.
Right.
Yes. Yes, start presentation.
Good evening, Subhash Kaul sir, Meenakshi Sundaram sir, Jayant Rai sir, and other moderators and co-speaker. I am Dr. Lakshmi Narasimha Reddy, practicing at a peripheral area in Telangana state, Nirmal. So I am a single consultant neurophysician in a single specialty operator center. And I'm going to share my experiences, how the stroke care going to, it's like evolved in this area from book to bench. So the evolution started from antiplatelets, anticoagulants to thrombolysis, and now we are going for mechanical thrombectomy also. And so it is since the past 4 years I'm practicing here. From journey I started from 2018 to 2022. So with this brief introduction, I'm going to cover my topic under the following headings. That is challenges which we have in this area, facts and figures, case scenarios, and conclusion. At the last, we'll go for panel discussion. So my limitations in this area are, it is a single specialty operator center. Until 2020, we had a 4-slice CT scan only. In the year 2022, we had a 96-slice CT. And recently, in August 2022, we had a 1.5 Tesla MRI. And apart from this, there is a lack of awareness in the general public regarding the early acute stroke symptoms. And next is the counseling and cost of thrombolytic therapy, and of course, the complications. So next, the main concept of treating stroke, a stroke patient is basic thing we all know is the brain is time is brain. So we would focus on this concept only throughout the session. The facts and figures are, first case of thrombolysis was done after my DM course is in 2018 at this periphery area. And after that, hardly I've done 10 to 12 thrombolysis until 2020. That is because of basically lack of awareness about the acute stroke symptoms. And for the past 2 years, the rate of IV thrombolysis has dramatically increased. Now the concept is shoot and ship. So the mechanical thrombectomy facility is available for me 3 hours away from this area. So with this background, I would go to the case presentations. Like first case is the 45-year-old smoker, is an alcoholic presented with sudden onset of weakness of left side of the body for the past 3 hours duration. He had a history of right hemiplegia 4 years ago and recovered with MRS of 1. So presentation NHS was 15 and he is on admission to GRBS was 240. That is de novo detected diabetes and go to needle time was 30 minutes. At the time of discharge, MRS is 4. 3 months follow-up MRS is 3. So on admission, CT scan showed a hyperdense right MCA sign, and there is a chronic infarct in the left occipital area. So CT angiogram showed occlusion of right common carotid artery, and all the right ICA was able to traceable. This is occlusion of right common carotid artery, and other side there is a occlusion of the left ICA from its origin. This is a ICU room where patients used to see when we do whatever treatment, they used to observe there where I am doing thrombolysis with IV tenacity plate, and the other side the sister is connecting with the insulin drip for high blood glucose. So the discharge, the patient was wheelchair bound with the right tube inserted, and he was not able to walk with, even with support. Like without support, he was not able to walk. This is a follow-up 3 months period. He is able to walk and with the support of a stand walker. So issues for the case one was it was a old CVA, he had an old CVA, and in admission high glucose were there, high burden of atherosclerosis, and of course there is a window period of 3 hours duration. So case 2, this is a female 36-year young lady, known case of hypothyroidism using regular 75 micrograms of levothyroxine, presented with weakness of right upper limb and lower limb with global aphasia, deviation of gaze towards left side after awakening from the sleep, that is at 6:30 a.m. Admission in NHS was 18. On MRI, there is a mismatch between the DW and phase sequences, combined with the door to needle time 20 minutes. This is the ADC sequence showing a hyperintense lesion in the left coronary radiator, and the mismatch is there between ADC and the flare images. This is the video of the ADC and flare, where we can see there is a clear-cut mismatch, hyperintense in the ADC sequence, in the coronary radiator and parietal area, insular area, and flare did not have those intense lesions. Yeah. So this is angiogram of the same patient. So in complete occlusion of the left ICA from its origin. So this is also the MRI angiogram images. Occlusion of left ICA. So patient was after thrombolysis, he was shifted for mechanical thrombectomy. After mechanical thrombectomy, patient's sensorium has improved. The NHS come down to 10. Power in the right upper limb, lower limb was 2/5. So before thrombectomy, there is occlusion of ICA, and there is complete recanalization of ICA and complete refilling of ACA and MCA territories. So after mechanical thrombectomy on day 3, day 2, there was repeat CT follow-up CT showing hemorrhagic infarct in the corresponding area, which was of hemorrhagic infarct type 2. So at this point of time, my questions to the panelists and audience is like at this point of time, whether to what is the antithrombolytic therapy after mechanical thrombectomy in such patients? Do you give any anticoagulants for this type of patients? So by keeping questions aside, I will progress with the case. On day 3, patient had a massive pulmonary embolism and she succumbed. This is a 2D echo showing. 2D echo showing a dilated right ventricle and the right atrium. There is a free floating thrombus located in the right ventricle cavity. So after this, we'll go to the case 3. Here is a 80-year-old male thrombolyzed on 1st of October. Is a known case of hypertensive, presented with acute onset, slurring of speech, deviation of mouth, left hemiplegia of 2.5 hours duration. His presentation in HS is 12. ECG showed atrial fibrillation controlled ventricular rate. The door to needle time is 30 minutes. So this is the MRI of that patient immediately after onset of the stroke. We have done the MRI showing the acute infarcts in the right MCA, PCA, and MCA internal border zones, followed by angiogram showing occlusion of right ICA from its origin. So the angiogram images of and neck images also were done. They complete loss of flow in the right ICA from its origin. So acute ischemic shock in elderly, the MRI showing complete occlusion of ICA, infarcts in the ICA, PCA, MCA, PCA, and MCA internal border zone regions. Patient is traumatized with IV tenecteplase, shifted for mechanical thrombectomy. After 6 hours, patient has recovered completely with MNHs of 0 and MRS of 0. And digital substance DSA showing anterior cross-filling and complete occlusion of right internal carotid artery. At this point of time, patient attender, he's also a doctor practicing in my area, senior pediatrician. He declined for mechanical thrombectomy and the patient had a score of 0. So at this point of time, this is the ESA showing complete refilling, anterior cross-filling of the right MCA, right ACA, and complete occlusion of right ICA. So next on the day 3, patient became stuporous with worsening of weakness, and MRI showed at the term of point showed, sorry, complete increase in the infarcts in the corresponding MCA territory and correlated with clinically also it deteriorated. At this point of time, patient was underweight mechanical thrombectomy. So before thrombolysis, mechanical thrombectomy, you can see the occlusion of ICA and occlusion of M2 segment of MCA, and after thrombectomy, like ICA is opened, refilling of MCA is seen. It went well, and these were the extracted products thrombi from the mechanical thrombectomy, and this was the patient at the time of discharge after mechanical thrombectomy, recovered fully with NHS 0, MRS 0, and he is also doing well till now. He is in regular follow-up. So for this patient, the issues are is elderly. The issue is that when the NHS is very low with a large vessel occlusion, whether to go for mechanical thrombectomy or not. So with these cases, I would like to conclude the session. By guidelines are only to guide us, so we have to practically take decision individually for every case, and also sometimes we need to go beyond the guidelines by assessing the risk and benefit ratio. All the cases, case scenarios may not be the same when compared to those of the subject enrolled in the clinical trials. So with this, I would like to open the session for panel discussion.
Dr. Kaul, sir.
I think the cases are very good, and they can discuss about them. Can I request Meenakshi, is it there?
Sir, yes, sir.
You can start with the first case.
Sir, it's a phenomenal presentation, sir. 3 cases, the last 2 cases were really awesome in my opinion, sir. And we'll always have lingering doubts as we go through that. Only a person who is batting in the middle of the field will know how the ball comes up to the height of the chest, or to the right of the nose. It's very easy to comment from outside, but I can understand the dilemmas you would have gone through that. Really, the third case and second case were really having a lot of dilemmas. I have my own doubts also to ask. In the second case, the first time you gave IV tenecteplase as thrombolytic agent, and subsequently the patient underwent mechanical thrombectomy. There were 2 issues which were forthcoming. First is that the patient again developed a large vessel occlusion, not in the cerebral circulation, but this time pulmonary thromboembolism. That was the issue which you developed. So whether after having administered tenecteplase only 48 to 72 hours ago, can we re-administer that? I really do not know. There are some very odd papers. I'm just trying to click my brain. Offhand, it did not come to me. Maybe we'll learn from this audience whether we can give thrombolytic therapy within 48 to 72 hours again to the same patient. And secondly, the question that is raised is that how we could have prevented it, because 48 to 72 hours is a very, very short time, even for a person to have been bedridden and then to develop so quickly a thrombosis. That means that person has been, should be having some hyperthrombotic event, like for instance, a lupus anticoagulant syndrome or a APLA syndrome. One of these things should have been responsible. Young person And maybe that was the reason why this patient had such a big thrombotic tendency, going one to the venous and one to the arterial circulation. These are my thoughts, but really difficult case. Just I would like to learn from this learned audience whether we can give thrombolytic therapy so quickly within this. Thank you, sir.
No, I don't think you can thrombolyze again. You cannot thrombolyze again for the simple reason you have thrombolized once. And then once you have thrombolized, the reason why you can't thrombolyze again is that you don't thrombolyze a stroke before 3 months. Once a stroke has occurred, you can't, he will bleed into that. And there are some people, they say that you may, as per the guidelines, it's 3 months. As per the guide, because second time you are going to thrombolyze for probably pulmonary thromboembolism. Are you talking because of pulmonary thromboembolism? For that, you want to thrombolyze him again, second time?
He has thrombolyzed for the pulmonary thromboembolism. So can you show the next slide, sir?
No, I know. So you can't do that because that you are if you do intravenous thrombolysis, it will not go only to lungs; it will go to the brain also, and that's an absolute contraindication. The minimum time at which you can repeat the thrombolysis is 2 weeks, but that also is off-label, and that also is that if they are lacunar strokes, are very, very small. Because the idea is wherever there is a soft brain from a recent infarct, it will bleed. But the thing is that in pulmonary embolism, they, of course, in Nirmal, they will not have that facility, but in advanced centers, they can do mechanical thrombectomy in the lungs also.
Yes, sir.
Would have been which I mean, if it was available, that could have been done. But I agree with you that this fellow must be having some procoagulant state. Did he suffer from COVID recently?
No, sir. No, sir. No, sir. She is
Or no COVID vaccination.
No, sir. No, sir.
So what are your thoughts? What could have been the reason for this pulmonary?
General,
Do you think, no, but the other thing is that, normally you would think of after a stroke, if pulmonary, you see, after a stroke, pulmonary embolism is always a dreaded fear, which fortunately we don't realize. After all this DVT prophylaxis is due to prevent this only. But did he have DVT?
Sir, DBT, because he had recovered our power 2/5, and they're mechanically they're doing anti-DVT prophylaxis, but they did not any anticoagulation. And also the policy of anticoagulating a patient after mechanical thrombectomy is only if the patient had a cardioembolic stroke with atrial fibrillation or else any large ventricular cavity with dilated ventricles, there we'll have then the policy of anticoagulation is there. The two for minor transient ischemic attack we do second day, and minor stroke we do third day, or like relatively moderate stroke 6th day, and massive stroke will go for after 12 or 13 days as per the guidelines. So for this case, and that is only in case of the studies were done only. Indication is only for cardioembolic strokes with indications of atrial fibrillations or arrhythmias. And like for this case, I don't think anyone predict this one complication. Also, there's no indication for anticoagulation, sir. Regarding regarding thrombolysis, as you already said, until 3 months there is no indication for brain again re-thrombolysis. And pulmonary thromboembolism, I don't know how they treat, sir. With I think intravenous thrombolysis is also a contraindication, even though she had a pulmonary thromboembolism. Whether mechanical thrombectomy for pulmonary artery, I don't know, sir, how to manage.
No, I think after the mechanical thrombectomy, after you have done it, 24 hours after that, one can start antiplatelets.
The antiplatelets they have started, sir.
Okay. Now, yeah, that is okay. Now the other thing is that prophylactic low molecular weight heparin, I think there is no contraindication to that. One shot after that.
Okay.
You see, this case is a big eye opener to me. I have learned so much from this. Why I have learned so much is because really I have not seen hardly we give low molecular weight heparin one shot to everybody. All of us are giving. You also are giving, and I'm sure Meenakshi is also giving, even though it's not in the guidelines. And we give it. In fact, our residents, some of us think it works in stroke also. So our residents ask, sir, what dose I should give, OD or BD? So in their mindset, they think BD dose is for stroke treatment and OD dose is for DVT treatment. Now we discourage them to give BD dose because that is nowhere in guideline, but OD dose is given almost to everybody. But telling you frankly, I have hardly seen any, very less DVT happening or even pulmonary embolism. This is the first case that I have seen after stroke. But because of this, I think I will be very careful to at least give low molecular weight heparin because you never know. We still don't know what is the cause of pulmonary embolism. But if we go by the common literature, then it would be probably secondary to DVT with a patent foramen ovale. Meenakshi, what do you say?
Same here, sir, because thrombolysis will be very difficult in this setting. And regarding the anticoagulation, there is on Daimler's law. TAA same day, 1 to 3 days for minor stroke, 3 to 7 days for moderate stroke. Something severe strokes is up to 14 days. That's what you also mentioned. That's called Daimler's law. We practice that. Regarding anticoagulation, as sir said, we always give some low molecular heparin for DVT prophylaxis. We don't give BD dose at all. But this case, even taking that into account, within 70, it was 72 hours for PE, correct? So, which is a very, very short time for a person to have developed DVT, that too having undergone mechanical thrombectomy. That means the person was moving the limbs very well in bed, because you said this improvement was seen very well after that.
Yeah.
So, after moving the limbs, the patient, it is very difficult for us to think that the patient would have developed, DVT and then gone for PE, in my opinion. Probably, as sir was saying, there was DVT before itself. Probably the patient had an hyperthrombotic condition, as sir was saying, maybe COVID. Or I have seen a patient, I have seen two patients actually had similar problems who had DVT as well as stroke. And this was one was established lupus anticoagulation syndrome. We had it.
Oh,
Another patient was an elderly patient. We do not know. That patient did not undergo thrombolysis. It was in 2001 or 2, I think. That patient had come with a stroke. Beyond that time, only 3 hours window was there, and only alteplase was available, not with Boehringer. It was only with German remedies or something. At the time we had used, we didn't use that drug at the time. We had kept it, but we couldn't use it. But patient came beyond the window. After 10 or 12 days, I think the patient had massive pulmonary embolism because the patient was not anticoagulated. The patient came to us because of breathlessness. Straight away, P was diagnosed emergency. We spoke with the family. At the time we didn't have this much mechanical backup and all from the cardiothoracic team. We asked the cardiothoracic team whether they can do a thrombectomy. They said they could not do it. And then we went ahead and spoke with the family. For a massive stroke, we gave uh, medication. I think it was streptokinase or something, sir. The patient did not make it. The patient went for unconscious state and died. We didn't do a scan at the time to see whether there was hemorrhage. But later on, I realized it was definitely a wrong thing, because large stroke by itself is a contraindication for administering streptokinase. We gave that because it was completely hemodynamic collapse in that patient. We didn't have that, sir. Only 2 experiences of this. But anyway, it was a great case really, sir. It was an eye-opener, sir, as you said.
yeah.
And sir, my question is that for elderly patient with a low NHS score with the proximal vessel occlusion, whether to go for mechanical thrombectomy and what are the guidelines?
Is this your third case? You are talking about your
Yes,
third case?
yes, sir.
After third case, we'll do discussion about your first case also.
Sir, sir.
Right. So I have forgotten. I think Meenakshi will remember what was the first case. So let us talk about the third case. Meenakshi, what would be your policy in low NIHS? Actually, your case was not low NIHS. It was no NIHS.
No,
It was zero. But it was zero NIHS with a large visual occlusion, right?
yes, sir.
In one of the previous discussions here, sir actually quoted the article by Dr. Pooja Khatri, the PRISMS trial, where he also said that in low NIHSS, when the PRISMS trial was conducted, it did not show benefit. And sir also guided us that even if there is a low NIHSS, we should not hesitate to do thrombolysis. But this was pertaining to IV thrombolysis. Now, your case scenario is about doing mechanical thrombectomy in a patient who has got a low or no NIHSS. That's a very difficult situation. The literature, whatever it says, for instance, within the 4.5 to 6 hours, we use the rule of 6. The NIHS should be at least 6, the duration should be less than 6 hours, and the aspect should be more than 6. With this, we go ahead, which means your patient by the rule of 6 does not qualify for this. Even when we go by both the Dawn criteria and diffuse criteria, Both criteria, they clearly say if the NHS is low, you do not take up because it is not worth taking up this patient. This is what the criteria says. But I will also give our own perspective, what we have practiced in our hospital. Even if the patient has improved to the level of almost complete, we know that that ICU occlusion will give trouble definitely. The reason why he came to the stroke was not because of a chronic ICU occlusion. Over the chronic ICU occlusion, something else happened for that patient, and that's the reason why the patient had stroke. We will know that we'll have difficulty in guiding the catheter beyond that, but still we will offer to the patient. What we would offer is that we will give the choice to the family. They say you do whatever you want. I think I would have intervened in that patient at that time. If the family takes the decision by themselves, then we are safe because we are out. Because now we ended up doing a mechanical thrombectomy a good day 3 after the onset of stroke, which was really a difficult thing in my opinion. But this is thoughts not supported by literature, at least so far, whatever is available in my opinion. We'll take sir's decision as a final.
What was the before he improved? How much was his deficit before he improved?
Sir, before he improved, NHS is 10, sir, before improvement presentation.
So it was quite significant.
Sir, 10, sir. He improved after this one, sir, after thrombolysis.
No.
This one point has been mentioned, Dr. Reddy. When you look at the original MR clean data also, and after that, whatever was written, they say that go ahead with mechanical thrombectomy, irrespective of whether the patient has improved or not, if there is a large vessel occlusion. But I do not know whether this would include patients who have completely improved or not. I do not know. Maybe as sir was pointing out, we should have accepted the NHS 10 before IV thrombolysis as the criteria to go for mechanical. Is that correct, sir?
Yeah. But with your IV thrombolysis, he improved, right? He improved to 0. Now you see, the thing is, this is the evergreen debate topic, and this debate is being held for the last, I think, 3 to 4 years in all forums. Nobody knows the answer to this. Nobody knows. Why people don't know the answer is because both things happen in this. Some patients, your patient was absolutely normal, but your logic was that maybe he again throws the embolus, maybe he again, and therefore, because there was already a large vessel occlusion. So that's why you went. But the people who will be opposed to this view are the one, maybe you will cause the deficit by fiddling with the thrombus. Nature is trying to heal it, and nature has already stopped it. And if nature is stopping it, then why you are going and fiddling with it? And that happens also. That happens also in many patients. I think almost 50% of people in this situation, they will worsen. But other 50% will, you would have totally opened the block and all. So therefore, this is still sub judice. Nobody knows what is the answer. One of the things which in various debates which I have heard, they say that if the initial deficit was very big, which in your case was very big, and then the patient has improved, even if he has improved completely, go for mechanical thrombectomy, because that is a trailer of the movie which may come later on. That was a trailer of the movie. It has given you that patient can have aphasia and agnosia and all that. Now it is improved, but it can again come, because after all, the clot is still there. It's a fresh clot. It's not gone. It is very soft, and it can again dislodge and do it. These are the people who are in favor. And this is one of their, based on their lot of analysis and all, they found that. On the other hand, they say that if the initial deficit was very minor, let's say mild pronator or little dysarthria, then that probably means this fellow has got a good collateral system to support. That is the logic. This fellow has got a good collateral system, and in spite of a complete block, he didn't produce much deficit. So don't disturb him. Nature will take. But if his deficit was big, then he probably. So this is one thing by which you can go. Now, if you want to be a lawful person, in Telugu we say Ramudu Manchid Baludu, means good boy. If you want to be a good boy, then you should not disturb this, because guidelines tell us not to disturb. But if you want to be a little aggressive and all, then you have to take the consent, and then you have to take the law into your own hands and and you are doing a good job. I mean, you have finally helped the patient. But strictly going by guidelines, you don't have to do it. But nevertheless, you have shown us that how every time. But in this particular patient, no, uh, it is just your call. It is the call. Either way could is the right way, and you have to be able to defend it. Either way is the right way. If somebody, if you would have presented that you did not do anything and you just waited and watched, I would have supported you for that also. But that you did it, that is also good. But guidelines, according to guidelines in this case, as Meenakshi said, most of us would not have done anything. Now coming to the first case. What was the first case? Can you remind us? All your cases were interesting. I don't know why Meenakshi said only second and third. I thought first
No,
was
sir,
also
the
very
first case
interesting.
was about hyperglycemia, sir. There was significant amount of hyperglycemia at the time of thrombolysis. So he was asking how it would have adversely
That was
impacted the
that
outcome.
was one point, and there was second point also which you raised.
Old see history of recurrent old stroke, sir.
And at what window period was she thrombolized?
He
Almost
was
the end of
prominent
the
at
window.
3 hours, sir.
Yeah, sure. No, I'll give my comments and then Meenakshi will also give comments. No, as far as old stroke is concerned, we have already discussed it. Old stroke means if it is more than 3 months, you can straight away go ahead and give it. Don't worry. 3 months is the window. 3 years, 4 years, 10 years, that's not a problem at all. The question is that how early you can give. Well, again, as per the guidelines, not before 3 months. And recently we had a bad experience because we gave to somebody at 2 months and he had got a massive bleed. But so, we have to, in strokes, we have to protect patients, we have to protect ourselves also. And guidelines don't give you any leeway to go before 3 months. But in case reports and in individual consultation, individual comments and commentaries, people have said, experts, I don't mean people, but experts have said that if the last stroke was minor, like a lacunar stroke, then you can bring it up to 1 month also, but not in guidelines. But there are in the real time, there are situations. Somebody may be your own close relative or your boss or some VIP, and or forget VIP, some patient whom you care, and he comes with a stroke, and you want to help him somehow. Then you can think of giving it, but just make sure that the infarct should be very small. It should have been very small, something like a lacune. Then you will get enough literature support, not guideline support, that you can give it. But 3 months is a good safety margin there. Nobody can blame us. And your second question was about the
Hyperglycemia.
yes, that is very interesting. That is extremely interesting. I am sure Meenakshi will have some story to tell about hyperglycemia because our experience is common in thrombolysis. All of us have faced same. You see, this hyperglycemia used to be a contraindication when I knew TPA. And I have known TPA ever since it came. I'm not talking of tenecteplase. I'm talking about the alteplase, when it came first time. In the original guidelines, it was a contraindication. And contraindication was any person having sugar more than 500, you cannot thrombolyze. And the rationale there was, which still stands, that in hypoxic tissues, there's an interaction between the glucose and the hypoxia and the TPA. Chance of bleeding is very much. Hyperglycemia is thought to be it's very strange, but it's true that hyperglycemia affects the RBC behavior. And it is one of the predictors of hemorrhage also. I would have intuitively thought it's a predictor of ischemia, but it's a predictor of hemorrhage, high blood sugar. So therefore, because of the fear of bleed, it used to be a contraindication. So I had a patient in cardiology who developed a stroke. And the cardiologist told me, he was as usual, an aggressive cardiologist. He told me, come and thrombolyze him. I said, I cannot. Her sugar is 550. He said, so what? We'll lower the sugar. And he just put an insulin drip on one side and he made me give. After taking consent against the guidelines, we lowered the sugar and we gave the thrombolysis and the patient improved also. And eventually in next few years, it was found that it was removed as a contraindication. Now there is no longer a contraindication, but you have to know that the outcome may not be that good. In patients who are having high blood sugar, their thrombolysis outcome may not be, but still it will be better than not thrombolyzing. I think we have seen that it will be better. It will not be better, if the patient did not have hyperglycemia, that outcome would have been better. But if the patient has hyperglycemia, still the outcome will be better than not thrombolyzing. So I think that also is no longer a controversy. You have to only lower the sugar as soon as possible with insulin and thrombolyze him, just as you do with blood pressure. Meenakshi, for your experiences on hyperglycemia.
So the question which Dr. Reddy raised, I think, is like this. The patient came beyond 3 hours. It was correct 3 to 4.5 hours window, and he was trying to see whether the ECAS-3 guidelines are binding upon us. That the patient has got a past history of stroke, the patient has got hyperglycemia. Should we go ahead and thrombolyze this patient? Was this a question raised, Dr. Reddy?
Yes, sir. Yes, sir.
Yeah, I thought so. But as Sir had discussed this aspect in one of the previous meetings, what Sir says is that, see, the European guidelines was the one which mentioned that for the 3 to 4.5 hours window, these restrictions are placed additionally to whatever was originally thought of as contraindications or relative, but all those are relative contraindications. And the reason when you look at the literature is not because they are absolute contraindication. The reason is because the European medical authority, the regulatory authority, did not accept it to be utilized in their guidelines until these regulatory things were put, that age is contraindicated beyond this age, more than 80, hyperglycemia, previous stroke. If these three are exclusionary criteria, they put it like that, and then only they will give approval for regulatory authorities. That is the reason why these are additionally added in addition to what was ECAS-3 data, and that is why it came to practice. But in practical purposes, we don't look at this at all. Whether 3 hour window or 4.4 window, we are using identical guidelines. That's what Sir discussed in one of the previous meetings, I remember. But now that tenecteplase has come to be approved for the 4.5 hours window, this hyperglycemia as well as this age, this previous stroke may not be really considered as binding upon us not to use these medications, what I would think. But Sir said hyperglycemia would really give some trouble to us. There's no second thought about it. At the same time, when you look at as a snapshot of treating hyperglycemia aggressively, if you look at that, for any ICU diseases, when hyperglycemia is treated aggressively, that is aggressively means you get the sugar below 140, prognosis actually is against us. That's a surprise for us. So now the recommendation is that you should be aggressive, but not too aggressive. The sugar should be around 140 to 180. Yeah. That is the best target. Less than 200, more than 150 is what we request our physicians or endocrinologists to give us in that time. These are my thoughts in this case.
Yeah, I agree. I agree completely. I think that dimension which you brought is, it was probably in context of the crossing the 3 hour window between 3 and 4.5. Should we exclude patients with the past stroke and diabetes? So you rightly, I completely agree with you. It's a relative contraindication. And the reason why they were excluded is because they had not included them in the trial. Not that they would do bad. They were excluded from the original trial, therefore they're excluded from guidelines also. But from legal point of view,
the previous talks.
Yeah, but for our own safety, it's important to take the consent of patients and then. Okay, I think we're already at 8:45, and I think we had a great cases, Dr. Reddy. Thank you so much. Yeah. So we go to the second speaker.
Dr. Venkatesh, sir. Yes. You can unmute yourself and start presenting. Dr. Venkatesh, sir, you are not audible. You can unmute yourself. Hello. No, you got muted again.
Hello.
Yes. Now you are audible.
Okay.
You can share your screen from
Am I
the
clear?
option below.
Yes, you are audible now.
Okay.
Yeah.
And my screen is also visible clearly.
Yes.
Okay. So good evening to all. I'm Dr. Venkatesh. I'm practicing Thane. I'm not attached to major hospitals. I'm practicing nursing homes and attached to a government college. So basically this is important because stroke needs hand technology with cath labs and MRI in hospital. So with this background, I will be sharing, this is only one case, and I think so In last case, all three were combined and discussion was at the end. I will, in this case, I think we'll discuss as the case goes by. So I will start the case. This is a 71-year-old gentleman who has no past history of diabetes, hypertension, dyslipidemia, or any cardiac disease or any stroke, but he was a smoker, regular smoker. He presented with right hemiparesis in December 2021. The symptoms had lasted for about 10 minutes and they recovered completely. MRI had showed left MCA infarct, cortical, it was tiny infarct. Angiography, etc. was not done. He was not seen by any neurologist at that time, and he was discharged on antiplatelets. But after 15 days to about a month, he had stopped all the medications, and he had continued smoking. So in February, now that was in December, after about 2 months, he had acute right hemiparesis at around 12 p.m. His symptoms lasted for less than 30 minutes and were recovered completely. And then he was brought to the hospital. From the hospital, basically nursing home, then he was sent for MRI, and MRI diffusion was done. The practice is MRI and CT scans. MRI diffusion they do and CT scan they do. So MRI diffusion was done. This was the MRI diffusion. So as we can see here, tiny specks in the white subcortical white matter here, in the cortex here. So this was the infarct. So though the recovery was complete, he had developed this tiny infarct. So basically, in this between the TI and stroke, TI what we called as transient episode of neurological deficit caused by focal brain, spinal cord, or retinal ischemia without acute infarction. The endpoint stroke is biological event rather than arbitrary 24 hours time as it was earlier. In our case, since now though the clinically symptoms has completely recovered, but imaging had shown tiny infarct, so the diagnosis will be ischemic stroke with completely recovered. But my question or doubt is, even sometimes we have seen that DWI changes are time dependent. If we do it early, we might miss it also depends on MRI, strength of MRI, whether it is 1.5, 3 Tesla, etc. And tiny infarcts can be missed even between the cuts if they are tiny, if MRI cuts are taken. And in posterior circulation, very commonly we have seen. So still, this is a normal question, but whether we should be bound by these definitions of TI, stroke, minor stroke, tiny strokes to the sir.
This is the end of your case?
No, sir. In this way, what I will do, sir, I will be going with one questions what I have, and then also we can have the discussion, sir.
Well, I would say that we should not differentiate between TIA and stroke, but we go by, to facilitate our work, we go generally by the guidelines, right? And because guidelines also come from literature, in some cases we have to go beyond guidelines when the guidelines don't, when guidelines stress us or confuse us or don't have a clear answer, then we have to go beyond guidelines. But as far as it is straightforward, we go by guidelines. Now, in this case, for instance, why it is important to differentiate between TIA and stroke is because why it is a stroke is because there is an infarct there. And why it is a TIA? Because he has completely improved. Now, and you didn't tell me about the vessels. Vessels were normal.
Like I said, sir, this was patient had come to a nursing home. From there, general practitioner had sent for. He had completely recovered till he reached the hospital.
So we don't have knowledge about vascular anatomy.
Yes, presently no.
So this patient had a small infarct, but he had completely recovered. Since he had completely recovered, it is important to know that the difference between stroke and TIA. Because if it's a TIA is completely recovered, then I would not like to expose him to the risks of thrombolysis. Because what will I achieve by thrombolysis? Nothing. He has recovered completely. There's a small dot in the brain. That's okay. So it doesn't matter. On the other hand, if I knew that he has got a MCA block also, then I would have a fear that he may again, and that will be in the same dilemma in which we were in the last patient. But if the patient has a clean vessels and is a small lacunar infarct and he has completely recovered, I would not thrombolize him at that time.
True.
Meenakshi, you have any thoughts?
Same thought, sir. We would not have thrombolized this patient. By this modern definition, we look at the TAA. The TAA now is defined as an acute event which recovers and the diffusion weighted abnormality shows no infarction. So this is one of the definitions that has been added to this. By definition, this if you have an infarct, it is now termed as transient symptom with infarction, TSI. The reason why we must know this is because when you have an ABCD square, which is ABCD square score, which is high, you admit them because you know that they have the risk of worsening. Also, when you have a TSI, you admit them because again they can worsen. These are two indications for admitting a patient with TA because in our private practice, for instance, because we are hospitals are expensive, relatives would not want to get their patients admitted. They will say, why should we admit? My colleague, Dr. Karthik, he once taught me a great wisdom, which I always pass on to my patients now. I tell them that, look, if you have a heart attack, you will get admitted. But if you have an unstable angina, you will definitely get admitted because you don't want to get an heart attack. Dr. Karthik, my colleague, says TAA is like an unstable angina. Admit them. Not because they will, we don't want them to have stroke, and if they have a stroke, you have to treat them. So 48 hours minimum admission for TSI as well as high ABCD square score. For that reason, it becomes important. This is TSI in my opinion, because there was an infarction in your MRI. Sir, is that correct, sir?
Yeah. Now, what happens is that, that is absolutely correct. Now, what happens is that in such situations, a patient who has a clinical TIA, and at the same time, he has got a diffusion abnormality. As Meenakshi said, even though it's a TIA, it has got a high chance of recurrence. So when you look at that ABCD score, that diffusion abnormality is also one of the points in that, and it is a very strong predictor. So therefore, you would admit him and expect that a stroke may come again. And now the question is, will you thrombolize him at that time? Suppose your patient gets another event 10 hours after your first event. Would you, as per our guidelines, you can thrombolize him because the word they use is that whenever a new TIA comes, you have to take the clock back and then say this is the time of onset, the second event. But your dilemma at that time will be, but there is already infarct there. So can I thrombolize him? And this we have faced, this all the doctors face, and particularly in the crescendo TIA, where patients will get 5 TIAs, 10 TIAs, 20 TIAs in a day. And in between there will be a small, these also, these flare changes and small dots and all. And on the 18th TIA, would you thrombolize him or not? And we have thrombolized with good success. And those minute lacunar infarcts have not bled at all. And those flare changes have not bled at all. But it has not come in literature as such. But to make the long story short, and this is repetitive. So I mean, every month we see a couple of patients like that. The patient gets 1 TIA, second TIA, by third TIA recovers, fourth TIA, the doctor is about to give, but again it recovers. And during these, every time you do the MRI, every time, and during some of these MRIs, then some dots do appear there, small ones. But then many of them end up getting a TP, and the attacks actually stop. And so that's it. But as per the guidelines are concerned, guidelines also actually allow you to do. They don't talk about flare changes and all those things at all. Their guidelines are saying that when the recurrent TIAs occur, then the onset of the stroke is taken to be the last TIA, the onset of the last TIA. But because we have got extra knowledge and all, we worry about those flare dots have already come there and some infarct is already there, it may bleed. In guidelines, there is no mention about that. You please read the guidelines again. But most of the guidelines are based on CT scans and all that. In CT scan, there is no concept of flare and all. So I think I think it is clinical. If the patient has recovered completely and then he gets in, then you give it. But don't worry about that small dot there. Yes, Meenakshi, please.
Sir, last time we talked about one thrombolysis for a capsular warning syndrome.
Yes.
Presenting as a recurrent one.
Yes. Same. I'm talking about the same series of patients. Majority of them have the attack stopped them later on. But there is no hard and fast rule. Some of them may worsen also, and some of them may add on.
Sir, that diffusion weighted changes are time dependent also. So sometimes if a scan done early, especially for posterior circulation, we may not see any dots also.
I think Meenakshi can throw more light on that.
And also the strength of MRI,
Meenakshi.
1.5 Tesla, 3 Tesla. And
What you're
cuts.
talking about,
Meenakshi, you can throw light on
there
it.
are a few patients who do have no changes on the diffusion weighted imaging, not necessarily because of time. They are purely diffusion weighted imaging negative strokes, well known in posterior circulation, which you mentioned. Even in an ACA territory, sometimes you may not pick up the infarct initially. We have had dilemmas like that, obviously. Then it is a clinical decision. If a person does not have anything on the brain, on MRA, and by definition of TAA, the patient is completely improved, we cannot presume that there was an infarct that was missed by us on the MRA. Clinically, no infarct, clinically, no deficit, MRI, no infarct, then to thrombolysis will be a very difficult call, I think, really. At least some deficit is there, then we can ignore the PRISM's data and go and thrombolyze them. But there is nothing on the MRI, nothing on the clinical count. It will be very difficult to convince ourselves about thrombolysis even before we go to the patient. This is what I think I would do. Sir.
I completely agree with you. It is true that in diffusion abnormality in posterior circulation strokes, I think there are about 4 or 5% which you may not pick. And what is mentioned in literature that eventually you will pick them if you repeat it after 2 weeks. I have also, not 2 weeks, 2 days. And I have also seen one patient, which I am planning to report for the last 2 years, but never had the time to do that, where in the anterior circulation also same thing happened, as Meenakshi, you said. That patient had a internal capsular infarct. It did not show in the first one. Patient had a deficit, but on the second day it showed that. That is true. That is known, but it is rare. Let me tell you. More often than not, if you think of a stroke and your diffusion is negative, more often than not, it will be some other etiology. You can keep this as, but you cannot comfort yourself thinking that no problem, it is still a stroke. You can have diffusion. Diffusion negative strokes are there, but they are rare. Always think of some other possibility. And this thing usually happens more so in vertigo. Patients who are having diabetic, hypertensive, and suddenly come with reeling vertigo and all, and you do their MRI, it's normal. And these patients sometimes because of severe vertigo may not be able to walk because they feel everything is wobbly and he has got ataxia also. And you may be tempted to thrombolyze, and many people have been thrombolyzed. I know that many people have been thrombolyzed with a normal MRI. I think I mean, if you can document it very well, explain to family and do it, you may do it, but be very careful. More often than not, it will not be a stroke. It will probably be a positional vertigo or something. So I think you have to be a little cautious about it. But it is possible. What you are saying is.
One anecdote can I share here, sir?
Yeah,
Can I be permitted, sir?
Please, yes, sir.
So there was a patient, I know that patient, Surili, no, I will not tell the name. One gentleman came to us with stroke, sir. So we had at the time, we didn't have MRI in our hospital at that time. It was in 2002 or 3. So went outside, came with the MRI. MRI was completely normal, sir. He had weakness. At that time, I wasn't aware that MRI can be normal. That was a 0.3 Tesla MRI. That was what was available in Madurai at that time. So I went and spoke with the family. I saw that the patient had weakness, and as usual, we will probe history, and found out that there was a lot of marital discord and fight and all those things. So quickly, I made a diagnosis of within quotes functional stroke. And the functional stroke, I said, maybe improve. 1 day, 2 day, nothing improved. And then I said he's not improving and the weakness was persisting. Got a psychiatrist to see, and a whole lot of psychiatric medications were also administered. And after about 5 to 7 days, the patient did not make any improvement. We did an MRI again, sir. The MRI was normal. And the patient had definitely weakness when I discharged him. Gave some psychotics and all those things, discharged him. In addition to aspirin, I'm not sure at the time statin was popular, sir. Only aspirin was there. We gave aspirin and spoke with them. And at the time, Trentol was available, sir. Gave aspirin and Trentol and discharged him. And then the patient came back after about, I think, 2 or 3 weeks or so. And 1 month, the patient had still weakness, significant weakness. What I thought was a functional stroke had definite weakness. And then we did the MRI again, sir. MRI was totally normal. Then I sent that patient, I said, I do not know what is happening, but anyway, stroke is there, we are treating. But only I do not know what it is. And I wrote a letter to my teacher, Professor Dr. Talley. I sent that patient to him for his opinion. Sir saw that patient, and in Nimmans, the patient underwent another MRI. That MRI, that they had 1.5 Tesla MRI. The MRI was completely normal. Dr. Srikanth sir was there. He reported on that MRI. MRI was completely normal for that person. And the patient came back to me. After that, patient had significant spasticity, has received botulinum toxin twice with a dense weakness which fits into MCA territory stroke. So this was my experience on that MRI negative stroke for the first time, sir. I didn't have the opportunity to publish him or anything. Sir, Dr. Tally sir will definitely remember this case. So the point it is mentioned is that we do see rarely some patients who are MRI, as I said, higher the Tesla, maybe higher will be the PK, but higher will be the artifacts also. It is not that higher ego. In fact, in one of the papers which I read, 1.5 Tesla is better than 3 Tesla for acute stroke. Some reason was given. I do not know how. Look at the paradox. That paradox was mentioned in one of the papers. It clicks my brain. Maybe I'll look into my literature and tell you. So don't have the idea that higher Tesla means better. No, it's not true. But at least he went to 1.5 Tesla, did not pick up anything. So MRI negative strokes are very well known. Point number one. More common with posterior circulation. One another patient I saw with the ACA infarct, which had definitely normal this one, but that patient had after 6 hours another MRI picked up. Routinely in our hospital, MRI negative strokes. 6 hours later, we do MRI again for these patients without additional charge. We do it, whether we thrombolize or not. That is a protocol in our hospital. For you, you can also look at that. That may be the explanation, I think, in this case.
I think you have to look at the whole picture. The clinical picture is paramount, no doubt about it.
So basically, he was admitted at nursing home. Power was 5/5 when I examined. ABCD score was 4, as sir had discussed. And patient had already received ecosprin 150, clopidogrel 75, Clexane 0.4, and atorvastatin. As we had just, sir, like we have said, everybody receives at least 1 dose of LMWH. So, like the question is loading dose of antiplatelet in ischemic stroke. So many times, general physician, etc., they try to give like in cardiac strokes in ischemic also, seniors also they ask or give loading dose. So anything regarding loading dose, sir? Because whatever I know, sir, if patient is planned for intervention, etc., then we give loading dose. So if patient is coming in acute infarct, whether in window period or out of window period, if window period and they are not willing for thrombolysis and out of window just 5-6 hours, etc. So do we give loading dose?
You can give loading dose. On the first day, you should give ecosprin 325 and you should give clopidogrel. You can, if you want, you can give up to 600. But please remember one thing. Yeah, I think you already said this logic is only for minor stroke. Minor, those who have got NHS less than 5 or preferably 3. To start with, if the patient is not already on aspirin, then you can give him 325 aspirin and clopidogrel. You can give 300 and you can give 600 also if you want. And then from next day onward, it will be 75. So loading you can do. This is as per the guideline.
So, and then I had explained to the relatives regarding recurrence of stroke because he had already past history of stroke and now he had come with again minor stroke. It was suggestive that he must be having some large stenosis, etc., severe stenosis, and he may again develop a stroke. He is admitted at nursing home, and after about 5 minutes, he develops a stroke before I leave the hospital. So this was the video. So this was the severity of stroke. Basically, he was complete aphasic with 0 power in right upper limb and lower limb. And this is immediately when I saw this. So patient had small infarct 3 hours back, and after 3 hours, now he has developed complete weakness, 0 power. NIH was coming about 23. So this is the case scenario, sir. So what next to be done? Because he's in nursing home, there is no CT scan or MRI available. If we have to send, then again call ambulance, etc. Sending him will take around more than kind of 45 minutes to 1 hour. It will go, sir. So what next, sir? What can be done for him if we are kind of examining him?
No, what was his power at that time? You're asking this question.
Zero power, sir. He had that stroke. Immediately after I examined him, I had explained to the relatives regarding stroke, mechanical thrombolysis, etc. Everything. And
he was already on 2 antiplatelets.
He was just received like a kind of loading dose of all these things. In low dose, he had already given.
No, but he has received 2 antiplatelets.
Yes, yes.
And while on 2 antiplatelets, he developed grade 0 power.
Yes, sir. Like immediately. It was not like more than half an hour he had received all these things and he had developed it.
And you are telling that neither CT is available, not MRI is available
in the nursing home. Yes, sir.
Then you can do nothing except watching.
And I have explained to the relatives that if we do the early we do it, the better is the thing. I had just explained to the relatives.
Without imaging, I don't think we have any justification in thrombolyzing. Without imaging, we cannot do it. Absolutely sure about it. In this case, there is some discrepancy which I would like to request you to clarify.
Yes.
So we have seen patients who really worsen, but to a point of receiving 23 score, if it was a large infarction, let us say a large chunk of MCA got suddenly occluded, more often than not, there will be an ICA which is affected. And more often than not, the patient would suddenly become drowsy at least. Though bilateral hemispheric involvement is required for maintaining consciousness, during an acute event, because of dynamic changes in the cerebral circulation, we'll see patients who become suddenly drowsy. This patient was completely conscious in your video despite the weakness, which is very unusual. If at all, we can explain by looking at some strategic site of infarction, a very focal area of infarction on the internal capsule. That was what was responsible. Probably at an ICA occlusion, a thrombus went there and went to that strategic region to produce that. Again, to have both to reach 23 score, there should be motor deficits and then should be sensory deficit. There should be aphasic deficits.
Yes.
So many deficits should have been happening because ultimately motor deficit 4 + 4, 8 will be the maximum for us. Then you have sensory,
he was complete aphasic.
Yeah, aphasic will be another 4.
Yeah,
then sensory will be 4. To reach 23 will be a very huge number in my opinion. For that to produce by that small, infarct, strategic infarct to produce that weakness will be unusual because his consciousness is well preserved here.
Yes.
So that clinical discrepancy to me appears gross. Maybe I will ask sir to clarify on this point.
And he is fully conscious also at that time.
Yes, conscious. Because it had just happened in front of us. Sir. Video was immediately taken when he had developed stroke.
That is, he had no imaging at all.
We did. So what had happened? Patient had come to around 12 p.m. to the hospital with history of around a stroke, which had lasted less than 30 minutes. Then from nursing home, he was sent for CT and MRI. So that MRI we had seen, he came back. It was around 3 hours after onset of the first.
What was the MRI showing?
MRI, this, sir.
What was it showing?
This one, sir. This one tiny infarct, and this.
No. If you see, this is a subcortical area, right?
Right.
So I would think that probably he had developed another infarct in the internal capsule, in the posterior limb of internal capsule, and sometimes you can have a severe. If you see in brain, it is the size and also the site of the infarct. It's little bit of even a lacune in the posterior limb of internal capsule can cause very severe hemiplegia. But still, it will not reach to 23. It may reach to 14, 15, but not 23 because he is fully conscious.
Yes.
And even if you think of a grade 0 power in upper limbs and lower limbs, how much it will become? It will become 8. If 23 means, but how is it 23? He's fully conscious, yeah?
He's conscious, but sir, he was obeying also, but sensory, etc. If you add up, it will come more than 15. It will come.
Okay, yeah. So then I can think of only a dense capsular infarct, which is probably extended. That can happen. These lenticulostriate arteries, no? You can have one artery, but then it can extend to other lenticulostriate artery. It can, because the parent artery is same. So that can happen. Sometimes, the lacunar strokes are progressive strokes. In 1/3 of the lacunar strokes are progressive strokes. They are the commonest subtype to progress is lacunar strokes rather than large artery strokes. So I would think that he has progressed. Right. And definitely, and the other possibility is whether he has bled, because he's on double antiplatelet. So you need the imaging. Definitely, you cannot
But
thrombolyze.
this
That's
the
for sure.
time period between giving antiplatelet, etc. So it is just hardly half an hour. Like we just gave, I examined him, and
Yeah.
before leaving hospital, he has developed.
So therefore, what happened then? We want
So
to know.
that was the
Can you
question,
show the
whether it
scan
is
again?
ischemic or hemorrhagic.
Can you
So
go
my
to the
first question.
scan again? Sir, one thought, sir.
Yeah.
Was this actually in the border zone territory between ACA and MCA, sir? And that is why he had a large vessel occlusion sitting down, producing this infarct, sir. We are
Possible.
seeing only one of the dots, maybe one big line will appear
Possible.
all above this and below that in one straight line
It's possible.
along the
Very much.
infarct. Was it a border zone?
Could be. Could be. And now the new infarct may be actually extended. Yeah, that's right.
But even
Right.
then, the 23 score is very odd in this case.
Then what happened?
So the question is, now I had explained to the relatives everything regarding stroke and time, and they knew ki the early we are, the more will be the recovery. So whether will it, like you said correctly, whether this will be ischemic stroke or will it be a hemorrhagic? So should we go directly thrombolize or
No.
because it will take about half and more than half 1 hour.
Meenakshi has answered that question. Go to the next.
No, sir.
Like in
Without another
capsular warning
imaging,
also, sir, we get continuous strokes. So we know if 2-3 strokes patient had earlier, the next is going to be again capsular warning, like ischemic stroke only. So in this case, patient early had now past history of ischemic stroke, again ischemic stroke, and now third event.
irrespective of that, resuming it as ischemia and thrombolizing, I think would be a very difficult choice for me to make. So I wouldn't have thrombolized without another imaging, sir. I wouldn't touch this patient, irrespective of whether you are in nursing home or anything. He better go to a place where facilities are available and then decision is taken, because
Only the
the
thing is
act of
time.
commission there can sometimes be catastrophic, because even when you look at that, thrombolysis is associated with real benefits in terms of morbidity, no doubt about it. But it has got a mortality behind this. So I do not agree with the fact that we can thrombolyze without another scan. I wouldn't do it, sir. Maybe sir
Nobody
can
will.
clarify.
Nobody will do it. Nobody. It's the absolute contrary. So did you thrombolize? That's what we want to know.
Yeah. So what had happened, I had explained to them. He was a young chap and he said, so we'll go with thrombolysis and we'll take him to some place because it is going to take time. And so with consent, etc., he was thrombolized and shifted to a higher center. Sir. That is what was done. Though it is out. That's why that question was there. What is to be done? So
then what happened? What was the outcome? Did he start walking?
Right. So again, like we had discussed earlier, sir, whether one should thrombolize a patient who is recurrent stroke within 3 months. And like you said, if it is tiny infarct, we can. So in this case, he just had tiny infarct and we can go ahead with thrombolize. And if patient are already on anticoagulation, etc., low molecular, if patients received in low dose, we can thrombolize. So literature-wise, we can get those things. Sir. So this was the scan done in the. So I could get the scan, sir.
Okay, go ahead.
Yes.
No, go ahead. Go ahead.
So this is the scan from the institute. This was the scan which was done at the institute when patient had reached there, sir. And we can see here a diffusion. This is large infarct, including like
Meenakshi, you are right. Meenakshi, you are right.
Are involved in patchy infarcts.
Meenakshi, you are right. It was border zone only, and this is a large artery. Yeah.
There is obvious ADC drop and flare was normal. But like we can see the ICS completely occluded. We can't see. So he had developed a large massive infarct in the AC MCA territory, IC occlusion basically. And since he was thrombolized, he was taken for intervention. And that was the scan. And he could reach there and everything was done. And it was around more than 6 hours. That was sure. They were saying 8 hours. But so whether he should undergo intervention. This is
Yes.
flare.
Absolutely, intervention is a must for this person. Are there flare changes?
So this is flare, sir. We can see the flare scan here, sir. You are able to see it.
Yeah.
It is
Absolutely,
normal.
we can go ahead. No hesitation in going ahead. I would have gone ahead and accepted it. For mechanical is a must in this patient, I think.
Yeah, because even though he has crossed the 6 hours time window, because of there is no flare mismatch.
No complications. Because 6 to 16 hours, you can do the diffusion flare images with this one, or you can use criteria of both diffuse or dawn. He would fit into both, in my opinion.
Yeah.
So, like you have said, intervention was done because there was no flare mismatch, and this was clot which was removed, and we can see the artery recanalization of ICS. This was very well recanalized, and the issue was again they have also found occlusion in the MCA territory as well as something in the AC also, sir. So there were distal occlusions also which were visualized on DSA, and MC was intervened. AC they could not, and this was post intervention. He has slight bleed in the AC territory when they had tried to intervene most likely. So that was the scan next day, which was. So this was the scan post intervention. And now he is obviously alive and following up. So he can walk without support. So that is the thing, sir. Now he is walking with minimal aid and speech has also slightly improved. So he is able to walk independently and they are happy.
No, I think it's a great case. I think we agree with you, except we have reservations about your thrombolizing without imaging, but that but then that was the probably
because
what you thought at that
still
time.
with whatever speed with they went, they had crossed 6 hours also. So everything and intervention was done.
But one thing is there, the thrombolysis which you did had not recanalized the vessel.
Not recanalized because it is like I say.
Right. And there was no clinical improvement also immediately after that thrombolysis.
No.
And in fact, the part of the bleeding could be one of the contributory factors could have been the
possibly. Interventionist said that they were trying to maneuver the ICA.
That's also possible.
They couldn't. And
but
while the bleeding was only in that region.
That's possible. No, but I think it's a great case. But probably the only thing where outcome is good and that is great, but still we would not thrombolize without imaging. That was to take a too big a risk, you know. So that nobody would take that risk. So, even if it is not. You said we took the consent. That is fine, but you see, you have to know one thing. It's called informed consent. Under consent, also we have to give him a reasonable choice.
True.
So what consent I should take, that also, because doctor is in a tremendously superior position when we are talking. Patient will accept
it depends upon how we convince him.
So to first of all, we have to be ourselves convinced, giving him. Just allow me to say that because there is so much a good thought. We are thinking loudly. You know, we cannot put everything on the shoulder of the patient. Patient's knowledge level is zero, and we virtually are a god in front of him. You know, the comparison between patient's knowledge and our knowledge is 1,000 times. So then you tell him that, look, I'm thrombolizing you, all responsibility is yours. Will you sign it? Poor fellow will sign it, yeah. But taking the consent is not. But on the other hand, it is good to take a consent after you have done CT scan. Then we can take a consent that, look, there is a clot. It may disappear, may not disappear. So that thing, what consent we should take, because there is so much of power in consent that we need to use that power judiciously. That is my opinion. But case was great, nevertheless. So much of learning. Really, thanks for sharing it. See, where will you see this case? You may open 100 books and 100 clinical trials. You will not know. And even if such cases happen, nobody will present it. They will keep it to themselves. So thank you so much, Dr. Bolgave.
The other thought, sir, I had given was, sir, the medication which he had received were like within half an hour. So I thought the effect of which will come, like whatever risk, bleed, like you had said. The second episode was kind of extension of earlier ischemic event rather than.
No, you're right.
bleed.
You're right. There was
one of the.
Your logical train of thought is correct. That's what happens in capsular warning. But it's good that you brought it up, and it is also good that we are equally telling you that probably it was not a right thing to do for the safety of patient. But what I'm excited about is our capacity to discuss this upfront. I tell you, I had one of my very close friends in Hyderabad, and one of the very prominent neurologists. He gave thrombolysis to one patient, one doctor's brother, and the doctor is from USA, and he was visiting. And this patient, after thrombolysis, developed, he did not improve. In fact, he worsened a little bit. And they did a CT scan and they found that that the infarct was there. And then this fellow told him, this American doctor, give him heparin. Give him a heparin infusion. My friend told him, I can't give him heparin. I have given him a TPA just now. But Americans are very fond of heparin. They talk against it, but end up giving it. This is all over the US. Even now, in most of the emergencies, heparin is given. He told him, give him heparin, I'm telling you. He said, but it is on your responsibility. He said, yes, it's on my responsibility. And this was, I will not even name the hospital because then you will get the clue. So he gave him heparin and the patient recovered. and it was post-TPA heparin he gave and the patient recovered. And I was so excited by that. I requested that doctor to present that case in a clinical meeting. He refused to present. He said, no, I can't present. People will criticize me. They will throw brick bats. I said, no, but somebody will learn. He said, no, I don't want. So this is the beauty of this forum, that we are able to, discuss these cases. And but at the same time, I think Meenakshi and me, both of us, would advise not to, because it's not just 5 of us. 100 people are probably watching us. Probably we'll never encourage without imaging to thrombolyze. Meenakshi, final word is yours.
No, not final words, sir. Semi-final, sir. There are some semi-final questions to ask, sir. It was a great place, Dr. Venkatesh, sir. Thank you very much. Fantastic, really. And the proof of pudding is in the cake because the patient is walking very well. But some thoughts really, are really disturbing my mind. Can I put it across, sir?
Please.
Now, when we look at the time windows in this patient had some, weakness like presentation. He came to the hospital. That was, after that, the patient was sent outside because it was nursing home without facilities. Went out, got an MRI, came back. The MRI showed some infarction. And then in the hospital received medications, clopidogrel, aspirin. And in front of our eyes, the patient developed stroke. So if you just put it across on a time span, at the best of the time span, it would exceed 4.5 hours. Because the patient has to recognize the weakness, come to the doctor, reach the nursing home, be evaluated, go back, get the scan done, come back, then we analyze, and then it happens. Why this is important for us is that time concept is because it has been shown that when you exceed the time window, the risk of hemorrhage also increases. That is an important point to see. Unless we see an appreciable penumbra, for instance, for altiplase, they had a penumbra which they showed up to 9 hours. And now for tenecteplase, they had a penumbra which showed even up to 24 hours. But the penumbra was shown, this deficit was shown, that the infarct was not seen. All these things were taken into consideration. But for that, on a named manner to thrombolysis beyond 4.5 hours is a difficult task. And that was also proved in your case because at the end of the day, the patient did very well, but the patient did have an hemorrhage. Fortunately, the hemorrhage was much in the anterior area beyond the motor area. That's the reason why the patient did not have much deficit. The patient, you escaped. The patient escaped, you also escaped because it went away from the motor area. But definitely you would have had your, heart in your mouth because the ICP would definitely go up. The moment there is a hemorrhage, the ICP would go up, the sensorium will drop, and then for 24 hours we had to have the headache as to whether the patient will worsen or not, whether it will be empty or not. And on the top of it, in a corporate hospital, we'll have the headache because for a mechanical thrombectomy, the patient would have been given a big bill, and the patient will be expecting quick results. All these things will be really headache. So the thrombolysis sir was saying whether it was worth taking that risk is to be really kept in mind. Some of that could have been contrast also. Sometimes contrast also appears white there, but really it was a big rounded thing which I thought could have been a bleed. So that was a very difficult thing. Sure, it was a great case because the patient improved, but really you are one of the warriors on the Kargil area, I think. So.
Yeah. So, anything else? Any other case?
Sir, you have the final word from you, sir.
Final word is the word what I said in the beginning also. I think they had these are all cases on the edge. Each one of the cases, if you see, this is fighting on the edge. And we learned so much from that. And I think both the speakers really, their presentations were very upfront, frank, bold. These are bold presentations. These are presentations with bold themes. And they were very honest, and all the outcomes were told us. And I think future of stroke is safe with young doctors. So we are very happy, and I once again thank Emcure for creating this forum for us and looking forward to the next session. Over to Team Emcure.
Yes, sir. Thank you. So what a wonderful and interactive workshop it was. And I would like to thank Dr. Reddy sir, Dr. Venkatesh sir for presenting those interesting cases. Also, thank you, Dr. Kaul sir, Dr. Roy sir has already left, and Dr. Meenakshi sir for your expert comments and your great practical insights. We would really like to work under your guidance for many such future programs, sir. So with this note, I will close this session. Thank you, everyone. Bye. Have a happy weekend. Good night.
Bye. Thank you.
Thank you very much, sir.
Everyone, sir. Thank you, sir.
Namaste, sir. Namaste.
Happy Diwali in advance, sir.
Yeah, happy Diwali. Happy Diwali.
Sure.
Bye, sir. Bye, Reddy, sir.